I'm Sean Rogers. I'm the director of pediatric surgical epilepsy here at Cohen Children's Hospital, clinical assistant professor. And we are going to go through a bunch of what we do in pediatric neurosurgery. Uh, oh, spacebar. No. How are we getting to this space? Oh, yeah, there we go. Now we have to go back. Okay. I have no disclosure. Just don't the brain turns group can take the images and stuff. We always put it on YouTube, but no one else please take my images and put them on their own stuff. That's all I ask. I come from now a few training places. I did my medical school at Georgetown. I then did my neurosurgery residency at NYU. I then trained at Bellevue, the VA, NYU, and then I did a pediatric fellowship at Lurie Children's Hospital in Chicago, part of Northwestern. I have been now at Cohen Children's Hospital here in New York, located on Long Island, right at the border of Queens, for 10 years. And it's been really a blast. It's been so great working here, getting to do everything we do for our children. It's been really, really fun. And it's fun because we have this many sites. Part of Northwell is such a huge company, essentially. It's the #1 healthcare provider in the state of New York. It has more employees than every other thing in New York. And you can see all of these different hospitals, all these different sites, they all funnel down to one children's hospital. So you can imagine our volume is tremendous. This is our main campus, but we also go out to Lenox Hill. We have LIJ, North Shore, Staten Island, Northern Westchester, you name it, we're there. And now it sounds like 7 more hospitals in Connecticut, ever growing. This is a long time coming. I was a medical student when Dr. Bookfar was at Cornell. Randy was my medical student when I was at NYU. So this is really a generational presentation through the brain turns, I would have to say, and a long time coming, well over 20 years of sort of people working together and seeing each person in a different stage of their life. So what is pediatric neurosurgery? So Wikipedia would say pediatric neurosurgery is a subspecialty of neurosurgery, which includes surgical procedures that are related to the nervous system, the brain, the spinal cord, that treats children with operable neurological disorders. When I was redoing this presentation for this year, I was like, oh, wow, this is really dating me. Why am I using Wikipedia for a definition like this? Why am I not asking ChatGPT? So now we're updated. I feel now I'm part of a different generation, but ChatGPT would define this sort of as pediatric neurosurgery is a specialized branch of surgery. It's focused on diagnosing neurological disorders in infants, children, and adolescents. I also operate on adults. It involves surgical procedures on the brain, the spinal cord, nervous system, addresses issues such as brain tumors, congenital anomalies, epilepsy, hydrocephalus, spina bifida, traumatic brain injury. Pediatric neurosurgeons receive advanced training, handling unique needs and complexity of young kids, and they also consider developing nervous systems to overall growth. I think this is an excellent definition, if even a computer made it up. And I have to say, this is sort of how I had already organized this talk and sort of showing you what we do for all of pediatric neurosurgery. Pediatric neurosurgery really goes back to about 1929. Frank Ingram, Harvey Cushing's protege, the father of neurosurgery, established the first neurosurgical unit in the world at Boston Children's Hospital. It was a dedicated career to the care of children. He wrote the first textbook. It really was, he was the pioneer in really how this sort of field of neurosurgery developed. He had imagination, intelligence, ability, and he inspired others. And Cushing really regarded him as Cushing was regarded as the founder of surgery, but Frank Ingram really was the disciple of Cushing and really the founder of pediatric neurosurgery. So there's about 50,000 neurosurgeons in the United States, in the world, about 2,300 in the world. There's under 300 pediatric neurosurgeons in the US. We specialize in brain and spinal cord tumors, epilepsy or seizures, trauma of the brain and the spine, skull anomalies, congenital brain malformations, hydrocephalus, which is sort of like water on the brain, spina bifida or congenital spine abnormalities, scoliosis now, vascular brain and spine malformations, and peripheral nerve injuries and abnormalities. We have quite a few journals that we publish in, Child's Nervous System and Journal of Neurosurgery Pediatrics is probably two of the biggest. They're two of our biggest societies. We have sections at the AANS, the CNS. We have a section meeting. This year is going to be in Memphis. And then we have an international society that really goes all over the world this year. That'll be in France. So how did my interest get into this? I really loved so many different aspects of neurosurgery, and pediatrics sort of lets you still be a general neurosurgeon in a subspecialty. You get to do brain tumors, you get to do epilepsy, you get to do spine surgery. You can see here in the top pictures, if you guys can see my cursor, this is a giant cell tumor that I took out just under the temporal lobe. You can see here an occipital cervical fusion for a trauma patient. You can see here the old way of doing this, the grids, the strips, and the depths for epilepsy. And then you can see here an endonasal clival chordoma that we took out in a little kid. These are all different aspects. You get to really go all over the body, and you get to do really interesting, unique parts of neurosurgery that adult neurosurgery really doesn't get to touch. So brain and spinal cord tumors are clearly one of my passions. It's what I've been doing for a long, long time, what I research on. It's really where we're trying to push the boundaries for kids. Unlike adults, we cure about 75% of pediatric brain tumors. It's a very unique field in the way we sort of get to see long-term care in kids. We get to see our patients grow up. We get to cure, unlike GBM. We get to truly cure kids. And it's a lot of those cures are based on surgical ability. A lot of those matter how much of the tumor you actually take out, that it's not really the biopsy. It's really a surgical procedure to get it down to almost like what we call a gross total resection, followed by either chemo or radiation, or sometimes even just watchful waiting. And the old adage is, what was sort of in the head, we want in the bucket. We tried to take out brain tumors. We would take out epilepsy. This is sort of the ultimate goal of a tumor, is to get it all out. And if you can, in a sort of en bloc fashion. But we've even pushed the boundaries now of that. So now we do these surgeries. We do stuff through the nose. We are able to do stuff minimally invasively. We're able to use robots, lasers, and we really now, with technology, have pushed the boundaries in children. One of my passions is also robotics. I also love 3D printing. We do a lot of 3D printing here for really complex cases and sort of teaching. It's also how we introduce the robotic use in children and able to get sort of to that 21st century, that really advanced stage of when we can offer patients really, really good programming, sort of using the high-end technology. Pediatric epilepsy is a huge portion of what I do. Tumors and epilepsy are probably my number two things I do. We use this ROSA robot. I have no conflict of interest here. It's probably the number one robot used for all epilepsy surgery all over the United States. This has dramatically changed the minimally invasive way that we do epilepsy surgery. We used to do big craniotomies, taking off bone flaps, putting those in freezers, and now we're able to put little tiny electrodes into the brain and get the same amount of information. You can see here, this is the robot arm that's able to move. This is a 3D printed skull. You can see here a black laser fiber that's going to a hypothalamic hamartoma that causes gelastic seizures on the right panel. We're able to do very minimally invasive things in order to change the entire trajectory of children's lives. And epilepsy, it's a huge burden on society. In the US, at least, it's 150,000 people every year. 1 in 26 people will develop epilepsy at some point in their life. 1.3 million to 2.8 million is the prevalence. And that's about 45,000 American children under the age of 15 per year that develop epilepsy. 20 to 25% of that epilepsy is going to be medically refractory. No medicine is ever going to cure it. And you're going to have to take those people either to surgery to palliate them or in order to cure them. These are some of the amazing cases we've been in the sort of the press for, some of the hypothalamic hamartoma work, some of the minimally invasive robot work, some of the endoscopic work. We do it all. There is probably no epilepsy surgery, I would say, that we don't do. This is really groundbreaking stuff that we're able to really push the limits on. Here you can see, this is one of the planning things for a bilateral implant where we put electrodes on both sides of the brain. Every one of these colored lines is going to represent an electrode. And we plan these out based on the EEG, based on the PET scan that shows hypometabolism in epilepsy, based on if there is a lesion, such as a cortical dysplasia or a low-grade tumor. This is sort of the planning. Yes, the video is playing. And where we're able to access into the brain. You can see each one of these is an electrode. Each one of these is going to sample multiple locations in the brain in order to record when a seizure happens. So we take away the children's medicine, we record seizures, we see what their semiology or their clinical manifestations of the seizures are, and then we see where is the electrical activity sort of starting and where is that network sort of propagating to in order to cure their seizures either with a laser, with an open surgery, or if there's not a possibility of doing that because it's in some language area or motor area, how do we palliate that with a device? There we go. You can see this. This is the robot in action. You can see here the robot arm is starly draped. The patient's under those blue drapes. Robot's taken in. It's registered either with a frame or with a laser registration. That arm articulates, very similar to the robotic arm that builds cars. You can see how the extensive planning with all the vasculature is planned out. And you can see there is not a lot of tissue exposed. We are going through percutaneous little entry points, through really tiny twist drill holes of the skull. And you can see why you'd have a very low bleeding rate because of the planning. You have a very low infection of the tininess, the small, minimally invasiveness of the hole. And you can see you're able to access tremendous amounts of the brain. I think that video is done. Yes. And then using that same robot, if we know an area of the brain is causing a problem, we can take a laser fiber. We put that laser fiber in the operating room. We are in then the MRI. This black line represents that laser fiber again into the hypothalamic hamartoma. This then patient goes into an MRI and we're able to, using thermography, burn essentially that area to disconnect the hypothalamic hamartoma from the rest of the brain and cure seizures. Usually that's gelastic seizures with hypothalamic hamartomas. You can see here, this is really high-end technology where we're having heat maps. And essentially we know exactly what the damage area is going to be when we turn these lasers on. We also get to put in heat targets so that we know we don't want to heat up the optic nerve. We don't want to heat up the hippocampus. We don't want to heat up adjacent optic radiation brain structures. And we protect that. And the laser turns off if we know the adjacent tissue is getting anywhere near a temperature that you would stun it, you would kill it, and cause apoptosis. So we can do that for epilepsy. We can take out entire temporal lobes. You can see here now we've even increased it by putting 2 laser fibers in. So we can increase the volume of tissue. This is a failed anterior temporal lobectomy and a hippocampectomy, amygdalectomy, and is still having seizures from the posterior margin of that resection. This is now able to go in instead of having to reopen the skull, reopen the craniotomy. You're able to take 2 laser fibers and you're able to get a massive amount of volume removed, essentially burned, cause apoptosis, and hopefully cure seizures. This is an amazing technology for rescue salvage cases because if anyone's ever done one of these cases, opening up an old craniotomy over an epilepsy site that's been observed is quite miserable. It is not easy. There's bleeding. There's always a little bit of denuding of the brain. These laser fibers give you an excellent option of sort of cleaning up extra stuff that you want to take out. And now we've even progressed. I've taken these laser fibers. I'm one of the researchers that's really pushing the limit on this, is taking laser fibers to pediatric tumors that are low grade, that are benign, or even a little bit higher grade, and sort of going into deep areas, going into areas that we normally would have trouble resecting without causing a problem. And now we're burning. You can see here the black laser fiber coming down into the basal ganglia, into the thalamus. This would be a deep tubular, go back. This would be a deep tubular case that you would really have to monitor closely. You'd have to really be careful of every little vessel because you do not want to cause a deficit in the thalamus, sort of the grand central station of the brain, where all these motor fibers, sensory fibers, connection fibers come through. And instead of having to put a tube, we're putting a tiny little laser fiber in, and we're getting a huge burn in order to cover the entirety of the lesion. And if there's a piece left over, if there is another area that needs to get done, you can put a second fiber in. You can come back and do another fiber. It doesn't, even though it's burning, it doesn't burn a bridge where we, like radiation, where we can't go back and give more, because there is no risk of radiation necrosis. There's no risk of secondary malignancy with these lasers. You can see here again, these little blue hash marks. Each one of these blue hash marks is a zone where I don't want to burn, right? I don't want to hurt the cortical spinal fibers that are running around this tumor, not through it, but around it. So this laser is going to turn off, if at all, these are tripped, essentially. If the heat signal in those three areas go above a certain temperature, it turns the laser off so that we know we won't kill any of those cells. You can see here the kill zone is the yellow zone. That yellow zone is pretty mathematically guaranteed to die off with at least apoptosis, if not even pretty instantly. And then we have now this purple zone that's in the new version that's able to give you sort of a marginal, possibly going to die off zone. And depending on how long the heat's there and how much apoptosis, you actually get even a bigger burn. You get that whole entire transitional zone that's also going to die. Wait, did I miss one? No. So we can do this in the top of the brain. We can do this in the back of the brain. This is a cerebellar tumor that we're able to cover. You can see here, this is the cerebellum. This is the area of the brain that gives you sort of coordination. This is what would give you a significant tremor, a shaking tremor if you were going to reach out. Your leg might have a tremor if you actually tried to resect through this normal tissue to get to this deep-seated brain tumor. But instead, you can take a laser fiber, go through the fovea of the cerebellum. You can not touch essentially any of the normal tissue on the way in. And now you can burn that tumor that's right up against the fourth ventricle, right against the dentate nucleus. And you can prevent really any deficit by having a fiber in there rather than having to go through significant brain tissue. This has given us a totally revolutionized sort of role in how we're treating low-grade tumors and how we are able to sort of stop it in its tracks early before it actually becomes a problem. But then there's also times where we can't do anything, where we can't take the epilepsy out. We can't take the temporal lobe out. We cannot cause a major deficit because the kid would not be functional. And you want functional patients. Just like you guys have probably heard in GBM surgery, you want to keep a very high KPS score. You want to keep a very functional patient because that's ultimately how they're going to do long term. This is a device that we implant for epilepsy, and it's a wire that goes into the brain or a strip of electrodes that goes into the brain. And similar to like an ICD for the heart, which is like a pacemaker, but that also shocks the heart if it goes into an arrhythmia. This is sort of pacemaker for seizures, doing a constant EEG. And if it sees a signature of a seizure, you're able to actually send an impulse back from either the generator, the wire, the strip, or between the two, or just one, to stop that seizure in its tracks. So sort of just like if a heart is going into an arrhythmia and you shock it back into a normal sinus rhythm, this is going to shock the brain back into a normal brain activity and prevent or abort that seizure. It's not perfect, it's not a cure, but it really, in areas of the brain that we cannot take out because we would have a horrible memory deficit, we would cause a horrible patient like that has no short-term memory by taking their hippocampus out. This gives us an amazing option to be able to get patients really close to cure. Again, we can place those with the robot. We can place those on the surface of the brain. There's a lot of different options. This is one of our patients that got published in the news for using the robot and helping the seizures. Really switching gears, going off to spine surgery essentially, and why this field of pediatric neurosurgery is so amazing. Nowadays, many of the pediatric neurosurgeons even specialize on top of pediatric neurosurgery. They just do spine surgery in kids. They just do epilepsy. They just do tumors. I still do everything. I still do a huge breadth of what pediatric neurosurgery has to, but there is definitely some more specializing now. But this is a cervical occipital fusion. You can see here using graft. You can see the rib I harvested and put under these rods. This is a occipital plate with these green screws that are in the keel, the thick part of the posterior fossa, the back of the neck. You can see here a decompression that needed to happen just over the foramen magnum, and then right by the arch of C1. You can see those rib pieces that were split and now are under the rods. That's actually going to be the long-term fusion surface between the two. And then you can see this transarticular screw going up through the pedicle, through the articular process of C2 to C1. And you can see then the bone graft around the rod. This we do in trauma patients. We do this in complex Chiari patients. Really sort of changing the view of what you can do in a child. This used to just be done with wires. This used to say you couldn't be putting these screws in kids. These kids fuse amazingly. These kids do really, really well. And another great use of technology in neurosurgery. And then we published on this. We published on, so how do you do Chiari operations, sort of minimally invasive? This is one of the brain abnormalities that's congenitally usually there. It doesn't allow normal flow of CSF in the posterior fossa. You can see here a big syrinx in the spinal cord that's built up, that black circle within the cervical spinal cord, that's fluid building up into the spinal cord. You see here in the back of the brain, the cerebellum is tonsil. These are peg-like tonsils down to the arch of C1. You can see here the foramen magnum up top here. And then some of these kids actually don't even need to have the door opened. All you need to do is give them bone space. So we actually compared which kids need to have that bone taken off and which kids actually need to have their dura opened and a patch graft sort of put in and their tonsils coagulated. This is one of the pretty common brain abnormalities that we see in pediatrics. And this is a severe one with a cervical syrinx, but they come in all shapes and sizes. And some are just with headaches, some are with myelopathy. It really depends on how severe the case is. We also do trauma. You can see here, this is a significant skull fracture, a comminuted depressed skull fracture well over the thickness of the skull. You can see there's a little hematoma within the brain underneath. We do these stealth incisions in children in order for the hair to grow back perfectly so that there's no real separation of the hair when they go swimming or they get it wet. You can see it's sort of like Humpty Dumpty trying to put these pieces back together. Thank children, this bone fuses very fast. All these bone pieces will solidify back together. There won't be really a hole or a depression, but definitely some of the trauma we see. We're a level 1 trauma center. This is kids get hurt, especially in the summer that we're having right now. This is what happens and sort of the part of the neurosurgery that will most likely never go away. We have things like dog bites, we have birth traumas, we have accidents, car accidents. I have to say one of the biggest things we see right now in New York is subway surfing. We see e-scooters, e-bikes, you name it, we have it. And really putting all these pieces back together is very, very rewarding to be able to hand back a baby to their parents. We also have to see some of the most depressing stuff. This is some of the things we deal with, like a bullet to the spinal cord. This was a gang violence with a bullet lodged against the spinal cord, and that developed a large syrinx. Eventually, the bullet comes out through a laminectomy. We also have to see suicide attempts. This is a through and through bullet wound that's not survivable. We have to deal with families. We deal with the patients. but there are other aspects, including non-accidental trauma in pediatric neurosurgery that is not for the faint of heart. And then on some of the lighter side, we have skull abnormalities. A lot of people probably have heard about plagiocephaly or flattening of the back of the skull. That's not really a deformity. It's really just because of back to sleep program. This is an infant skull in the middle, what normally would look like. You can see here there's a metopic suture in the front, an open anterior fontanelle. You have then coronal sutures. You have a sagittal suture, and you have then lambdoid sutures. If everything is correct and the brain is growing, these sutures expand, they eventually solidify, and they form your skull. However, if one of these sutures forms too quickly because of genes, because of something else, you get a very abnormal looking skull. You get a very funny looking skull that usually is very noticeable to parents, to children, and also to their caretakers in school, and unfortunately, fellow classmates. This top one is what's called sagittal synostosis, where the sagittal suture forms. You get a very elongated head, a very big forehead, a very narrow pinched in bitemporal distance and biparietal distance. Some people would call it like Mr. Peanut Head. You get this narrowing, and you need to be able to expand that surgically. A lot of these under 4 months, we're able to just take out where the suture is, and we use helmets to reshape the skull. You can see here on the left, the metopic suture, the front suture right in the front of the forehead. That suture forms or closes too soon. You get what's called metopic craniosynostosis, very pinched in trigoncephaly, it's called, pinched in forehead, and that looks like a bird's beak. That you need to flatten out with surgery, and you need to take wider. You can also do these under 4 months, and you can reposition them with a helmet very, very effectively. Lambdoid synostosis is one of the rarest synostosis. That's when the back part, that's usually when an ear goes way up because of a fusion in the back. These also can get done fairly early and have a great result. You then sometimes will have one coronal suture or both coronal sutures close too soon, giving you unilateral or bilateral coronosynostosis. We'll see a picture of that in a second, where it's like sort of the Rock, that movie star, sort of giving you that eye look. You'll see one of the kids in this will have that. This is a sagittal synostosis. You see the big, big ridge on top of the forehead. Correction, on top of the skull. You see here, the metopic suture is normally closed anyway here at this age, but this is the open anterior fontanelle you're seeing. You're seeing open coronal sutures. We'll play that video again. But you see a closed sagittal suture too early, and you have to remove that and widen the distance if they're late, or if they're really early, you can actually just remove the strip and then helmet these to reshape. You can also see this is a very big, bossy forehead in this child. And if you do these around 9 months of age, you have to take off the skull, you have to take down the face. You then have to take away the big, big portion of where that was fused. You then green stick, barrel stave the sides down to really widen out the skull. And then you're using these absorbable plates, these clear plates, to put all those pieces back together, creating sort of like a roll bar so that things stay apart, so they don't refuse back in a very tight fashion. And then you go from a very narrow skull to a very much wider skull where the brain is able to grow and move. This is that unilateral coronosynostosis that I was telling you about, where the eye looks up. This child is not trying to do this. This child at baseline has this elevation of the eyebrow, looking very surprised on one side. This is a very big abnormality that later in life just keeps getting worse and worse and worse. I think this is a video over here. Yeah. You can see here, this is a raised eyebrow on this side. You can see the open suture on the right side is open, but this left side has closed. This left side is closing and drawing that eye up. If you do these young enough, you can just take along that strip take away the suture and you can helmet these and reshape the skull. Later in life, you have to really take off the entirety of the forehead and really reposition everything to get a correction of that eye. There we go. This is metopic craniosynostosis. This is a young kid with a fused forehead. You can see a very pointed forehead in these pictures on the left. And then when you see them pre-op here on the right, this is a little bit later, 9 months old. So we couldn't just do a strip craniectomy and helmet. This had to be a full vaults reconstruction. You can see here this pointed forehead. This child is intubated. Again, you see that wavy way we're going to make the incision line in order to hide it. It's not going to be the straight line that's purple. It's going to be the wavy one. We essentially have to take off the entirety of the forehead. This is the anterior fontanelle that you're seeing where the bone is missing. You can see here the big ridge that's along the metopic suture. And we're going to then also take off what's called the bandeau. This is the band right above the orbits. And we're going to widen that distance with plates and a piece of bone. And these absorbable plates are going to put everything then back together. And now we're going to have a reshaped head that's going to fuse. All those bones are going to fuse back together and form what looks like a very cosmetically appealing child. Some of the other abnormalities we see in the skull are called dermoids. This is a very large dermoid. These are essentially like trapped skin cells at birth that grow over time. Linear growth, not exponential growth like a tumor, but can get very big and grow into the skull and cause deformity or pain. This is it cut open. You can see almost like layers of an onion, those skin cells growing over and over and over again inside. This is taking this one out.
Dura in the gaps.
So this comes all the way down to the dura. You can see this is coming out sort of like a golf ball. And now you have this crater to deal with. If you take these out as a young kid, they come out really easily. The bone is not this crater-like, and you barely have to do anything. If you wait, this was a 9-year-old. This is sort of what can happen when you really wait on these and let them grow significantly to a much bigger size. So hydrocephalus. Hydrocephalus is one of the biggest things that pediatric neurosurgeons deal with. This is essentially buildup of cerebral spinal fluid into cavities of the brain or ventricles. It increases the pressure in the brain. It then decreases the function of the brain. Usually it's a production. Every single day you're going to produce CSF. Adult, you'll say like a can of Coke. A can of Coke is produced every day and then you resorb it. You're in a happy homeostasis balance. The problem occurs usually in 3 different ways. One is communicating or non-communicating, blockage. That's usually blocked by a tumor, blocked by scar, blocked by something, and part of the ventricular system is dilated and you need to deal with that or create an alternate pathway. Communicating hydrocephalus is usually an absorption problem. That's from an infection, decreasing the absorption capacity of like the arachnoid granulations, or decreasing blood causing inflammation and causing a decrease of absorption, or a tumor shedding tumor cells into the CSF and that causing a problem. Then there's also a third thing that you see in adults called normal pressure hydrocephalus. That's not part of this talk. That's a totally different separate type of hydrocephalus. I would also have to say myelomeningocele kids have a different type of hydrocephalus, a very different CSF balance issue. A lot of those end up requiring shunts or ETVs. We can also talk about that at some point, but that's a slightly different type of hydrocephalus. This is the classic baby that has hydrocephalus that's not treated. Very large head, little tiny body compared. And you can see like the scalp veins are popping out. If you felt this anterior fontanelle, it would be widely spaced. Those coronal sutures and metopic suture, sagittal suture that we talked about earlier, those would be splayed and wide open. This is a baby's brain that's getting stretched and the scalp getting stretched because of all the water building up. You can see here, this is a 3D representation of where we would put like a shunt catheter or a Maya reservoir. This is a very big black is the ventricles. The brain is getting squished to the outer perimeter of the skull. And this is a trajectory that we've planned out for a shunt in the mid-pupillary line, just at the coronal suture. This is sort of a GPS system that we use in the operating room. And it's essentially plumbing, right? We use tools. Instead of the pipes, we're using tubes, silastic tubing. We're using valves instead of regulators to turn water on and off and program it. A lot of times we're using programmable valves in the United States, at least, in order to adjust the flow so we don't have to go back in and change it to a different setting. And that's usually done with magnets, and everyone has to be very careful about MRIs, even there's MRI compatible shunts nowadays with magnets. And there's basically three types of shunt. One's a VP shunt, or ventricular peritoneal shunt, where we put the tubing into the abdomen, into the abdominal cavity, where the peritoneum absorbs, based on surface area, that excess fluid. Sometimes we have to put the shunt into the heart, and the heart is going to essentially filter out that excess CSF fluid through the kidneys. That's a ventricular atrial shunt. Or sometimes we have to put it into the pleural space. The pleura of the lung, the outer covering of the lung, is going to absorb that extra fluid that the brain is producing that can't absorb, and that's going to absorb it based on the surface area of the pleura. So we also do ETVs, which is endoscopic third ventriculostomy. That's a hole that we place just anterior to the brainstem in order for CSF to get around a blockage. Here you can see this is the foramen of Monroe. You're in the lateral ventricle. This fluffy red stuff is choroid plexus. The fornix is draped over the foramen of Monroe. That's that shiny white right around the top part from 9 o'clock to 3 o'clock. You see here a septal vein. You see a caudothalamic vein over to the lateral aspect. And we're going to then go into the third ventricle. The blockage for this patient is at the cerebral aqueduct within the third ventricle. And we're going to create an alternate pathway for that CSF to get around the brain to absorb. And that's going to be made in the floor of the third ventricle, just anterior to the basilar artery and the mammillary bodies, and just posterior to the infundibular recess of the pituitary gland, and also posterior to the optic chiasm. You'll see here in the video us navigating through the foramen Monroe. You're now into the third ventricle. You see here, this is the fold right where the optic recess is, and this is where the optic chiasm is. You see here the red is the basilar artery pulsating in the distance just under the floor. There'll be basilar perforators that you have to be very careful to. These two bumps here, right here, almost like butt cheeks, those are called mammillary bodies. Those are big components of your Pepez circuit, of your memory areas. You can see here the redness is part of the infundibular recess. The white shininess through this is the clival recess. This is the clivus bone, or the tuberculum, that you're going to be seeing through this. And you can see this is flapping sort of in the wind, and we need to make a hole in that for the CSF to get through. This is a Fogarty balloon where we're puncturing a hole. This is a grasper where we're spreading the hole. And now you're seeing arachnoid, that white web-like material like Indiana Jones in the cave. You need to get through that too in order to make sure that the CSF can go all the way. The balloon is going to dilate this hole, because if this hole isn't at least 4 millimeters, it has a much higher likelihood to close over. We're going to plug this computer in. Hold on 1 second. Timeout. Are you guys back? Did it go away? We're here. Okay, you guys can hear me, right?
Yeah, we can hear you.
Perfect. Okay, we're back on that video. So we're good. Here we go. Through the foramen of Monroe, under the fornix, following the choroid plexus into the third ventricle. Mammillary bodies at the bottom, basilar artery pulsating, Infundibular recess in front of us, optic recess. We're taking that balloon through the floor of the third ventricle. We're spreading that floor of the third ventricle, and we're seeing the clivus. There's arachnoid in there. We're now widening that so that it's not going to scar back over and close. You're now navigating the camera to make sure there's no other things you need to fenestrate beyond the floor of the third ventricle. You can now see the pulsations of that and the fluid being able to get through it. Right anterior to the basilar artery and posterior to the clivus. This is another video. This is a video where we have very stenotic foramen Monro. I'm going to fast forward this one a little bit. So you see here on the CT scan, these are very large ventricles, the black filled spaces. There's also a schizencephaly on the left side. And the foramen Monro are very tight, and this is causing hydrocephalus just above the foramen of Monro. You can see here on the sagittal image, the brainstem, we have really good flow underneath, but no flow up top. So we're going to take that camera and try to open up again into the floor of the third ventricle in order to avoid the clogged off cerebral aqueduct. So this is us entering into the ventricle. This has no septum, so you're actually seeing bilateral choroid plexus here. There is no septum because the hydrocephalus has sort of worn it away. This tiny little area is the foramen of Monro, that tiny stenotic area on that side. And this is the choroid plexus again that's coming through. That's the other side that's also stenotic. You can see here the fornix down the middle. So first, we're going to take away some of that choroid plexus. We're going to burn it, essentially, so it stops producing a little bit of CSF temporarily. And it's also, we're going to try to get it out of our way. So you can hear more coagulation of the choroid plexus. Now you see in the foramen Monro, you see a little bit of choroid plexus anteriorly, which is in the third ventricle. We're then going to take this camera and get through that really stenotic foramen Monro. Again, burning the choroid plexus. This is a navigation device that's checking exactly where we are in the brain. We're trying to open up and dilate that foramen of Monro. These are the columns of the fornix. These two white lines down the middle that's separated. That's how you would do a transforniceal approach if you had to get down to the third ventricle. So now you can see here, moving over the foramen Monro, trying to open up and get our camera in. This would be a transchoroidal approach if you had to get through that into the third ventricle. We're running out of time, so I'm going to fast forward a little bit. You can see us now. We're about to take our camera through this area. Now we are in the third ventricle. You can see again the mammillary bodies. You see the pulsating basilar artery with its little tiny perforators. We're now going to take that balloon again and make a hole into the floor of the third ventricle. There's our balloon. The balloon now is through the floor of the third ventricle, and we're going to dilate this up. You see again the white clivus anterior to us, basilar artery behind us with the mammillary bodies. Making sure it's not going to scar back over. And now navigating the camera to make sure there's not another web that we need to go through, but you see a basilar perforator here, you see the clivus, you see it wide opening, what we call the naked basilar artery. All right, we're gonna go on to the next. We also do spina bifida. Spina bifida is an open occult spinal cord defect. This is actually the placode. This is missing dura, missing skin that has to get closed. Otherwise you get meningitis and leaking CSF. This is what it looks like all closed with glue. These can come in all shapes and sizes. This is one popping out because of the CSF that's underneath. You can see here again, the placode, the neural structures. This is essentially like L3, L4, L5, S1, all that, those neural elements are right there. You see the excess skin underneath and the bulge in the baby's back. These are the leg deformities that sometimes come along with that because those nerves are damaged in utero. And you see these club foot deformities. This is yeah, you can see this foot is twisted all the way backwards because of those deformities. This is what the closure looks like at the end. Close up the dura, the skin, the placode gets imbricated. So we have what is looked almost like a normal back. This is a cystocele. This is essentially just the meninges essentially are dilated with CSF. There's no neural tissue inside of here. And you can see this big hump on the back. We're going to trans-illuminate it with a flashlight. And you can see it's all filled with CSF fluid. This is what it looks like open. We have to then reconstruct and take away all that excess skin. We also now do pediatric scoliosis and neurosurgery. Orthopedics traditionally used to do a majority of this, but as less and less orthopedic surgeons go into scoliosis surgery, more and more neurosurgeons go into it, and this is slowly becoming much more a neurosurgical disease. This is a hemivertebrae. This is getting resected, the hemivertebrae, and then fusing above and below that with rods and screws, correcting this gibbous deformity. This is a major AIS scoliosis, but in a very young kid who still needs to grow their lungs. If you fuse them too early, you'll have very small lung capacities. And these are magic rods that are going in. These are rods that have a big magnet that can actually get adjusted in the clinic to grow with the patient, because we don't want fusion yet, but we also don't want the curve to progress and make it harder for surgery later in life. So these are percutaneously put in magic rods. We also do vascular malformations in the brain. You probably have heard in a few of these talks, cavernomas, AVMs. You can see here a cavernoma on the left. You can see here on the right a AVM that's been embolized. The green in here is onyx material that's embolizing some of the AVM here. You can see arterialized veins, arteries that are twistus, tortuous. AVMs for pediatric patients have a tendency to want to grow back and have to be followed for many more years than adults. We also do peripheral nerve conditions such as neurofibromas, brachial plexus injuries. This is a large neurofibroma, the brachial plexus. You can see here we also stimulate. Is that a video? We also stimulate and the nerves using devices. This is a brachial plexus injury, that classic turned out hand. And sometimes we have to lyse big neurolysis of this. Sometimes we have to reattach nerves and use normal nerves to splice in. We also have a big resident education thing here at Northwell. We have a huge neurosurgery department. We have awesome cadaver classes, awesome teaching. I think some of our residents are some of the best that we possibly could get. And we really, I think, put them through an education that is pretty amazing. We also do a lot of community outreach as pediatric neurosurgeons. There's hydrocephalus walks, epilepsy walks, vascular malformation walks, you name it, we do it in the community. Having children sort of as patients really is a very, very important thing to really touch base with the families and get into where they live and what they're concerned about. Whew, we made it through. That's one of our pediatric MRIs, and I am going to end there because I think we have 5 minutes left.
That's great. Thank you so much. Do you want to take the 5 for questions? Do you have some time?
Yeah, sure. Let's do it.
So we get a question here. What's the extent of the effectiveness of corrective skull surgery after hydrocephalus?
Skull surgery after so hydrocephalus, obviously the skull is big and the babies eventually grow into the skull. Correcting the skull for craniosynostosis, those are very effective, super effective, less than 4 months, still super effective even later when we have to reconstruct it. Those kids absolutely, I guarantee you see kids and adults walking around all the time that have had those surgeries and you never know.
How do you cope with the emotional demands of treating children with these serious conditions, especially in cases where the treatment doesn't exactly bring them back to the typical quality of life?
Yeah. So obviously you have to be able to compartmentalize. You have to be able to put things in boxes and leave things at work. But my work-life balance is definitely intertwined. I also focus on my children. I focus on my family in order to sort of get through those times. You need to have outlets in neurosurgery like anything else. It is definitely not for the faint of heart.
The question, is spina bifida the preliminary cause of that club foot, the turning of leg, or does that happen a lot on its own?
There's club foot for other reasons and like amniotic banding and stuff like that. But there's also that particular one is because the nerves are damaged because of the myelomeningocele.
Someone's asking the most rewarding and then the hardest parts of your work.
Obviously, rewarding is curing tumors, curing epilepsy, handing back a trauma patient to a family that thought the end was near. Those are obviously huge rewarding. Coming out of an operating room and getting big hugs from families is very rewarding. The hardest part is seeing children die. And probably even harder than that is non-accidental trauma or child abuse and seeing kids die from that. Gunshots are really horrible when those are preventable here. Those are some of the things I would say are really, they're hard to deal with.
Only imagine. Um, could you speak to balancing the urgency of surgery along with like timing that with the child's development and their brain plasticity?
Yeah, so earlier is usually better. Obviously, younger than 1, though, you're not myelinated, so it makes surgery significantly harder, and blood loss and coagulation is definitely significantly different. But your plasticity, right, is tremendous at a young age. So you can shift memory, you can shift language, you can take out half the brain in a hemispherectomy or disconnect half the brain, and everything transfers over to the other side, where you actually have motor function from both sides of the body transferred over to the other side. It's pretty remarkable what the plasticity in a child is versus an adult.
Maybe we'll end on this. There's obviously a lot of people here trying to get engaged in the neurosurgery community and research and things like that, and they're just wondering if you'd be open to sharing an email or something to be reached out to about opportunities like that and stuff.
Yeah, they should have my email. It's srogers at
Okay.
northwell.edu.
Okay, we'll be sure to share that with them. Um, yeah,
Yeah.
that's all the questions we have. Is there any final words you want to say to the brain turns this year?
Yeah, I have to say, medicine is still one of the most rewarding fields. Having a purpose, going into something that is good for everyone else, not just yourself, I have to say, is still extremely rewarding, no matter how many dynamics might happen in sort of the politics of medicine. This is still one of the most rewarding fields that you can possibly go into. So keep going, keep persevering, and I hope you guys are really enjoying this program.
Well, thank you so much. It was great to hear from you again this year. Yeah, I guess we'll probably see you next year then, eh?
Excellent.
Awesome. Thank you.
Perfect. Thank you guys for having me. Really, I hope you enjoy the rest of your day.
Thank you, Dr. Rogers.